It's a pleasure to be here with all of you. And well, the nature of an academic place, you have to have PowerPoint. So you're going to get a few slides from me. But the themes I want to share with you today is just what's going on in healthcare just nationally right now. And then I'll focus a little bit about Penn and what I think is going on in the local market. But to go back to the themes that the rabbi mentioned, an awful lot of patient care now has to be patient involvement and patient directed. And the baby boomers like me are aging, and one thing you find out, people 28 and 32 don't need health care. They may have a baby here and there, but by and large they don't need health care. But when you're 62, 72, 82, you come see us. And as I'll, to anticipate part of what I'll be saying to you, is the baby boomer generation has been the biggest age cohort for the last 65 years. The millennials just caught up to us. So like every issue the baby boomers have had, whether it was when I was a kid, getting into college and then getting a job and then getting married and midlife crises and then thinking about what to do afterwards. So everything, because we were so big, everything we worry about, and now we're worried about healthcare. So it's a good field for me to be in. I've been in it for a long time, as Harrison mentioned. So let me first give you an overview of what's going on. So first of all, you see some of the Democratic candidates are running for Medicare for all now. You notice that and so forth. Half of us are covered by private health insurance. Probably many people inside this room are covered. I'm covered by private health insurance at Penn. If half of us are covered by private health insurance, my guess is we don't want to give it up that fast. So while I'm generally sympathetic, as I'll stress in a moment, to getting more and more people covered, half of us in this country are not going to give up our health insurance, which is why Medicare for all is not going to fly. I mean, it's not just the opposition from the Republicans on this because they're opposed to anything the Democrats want to do, but essentially, and as you see, a good chunk of us covered by Medicare and Medicaid. The other important thing to see here, hospitals about 1/3 of healthcare spending in the country, and physician services are 20. So hospitals and doctors, about half of that. Drugs going up, all the great specialty drugs that we're bringing to the market from the Mercks and the Novartis taking up more and more of the healthcare dollars. But these things are important to understand as one looks at this kind of debate as to what's going on inside society. So, healthcare costs are going up. You don't need me to tell you that the average American has gotten his or her compensation increase the last 20 years through healthcare costs. Now, maybe not the people inside this room, but the average American is getting his or her compensation increase the last 20 years through healthcare costs. They're not getting a wage increase. Now, whether you say that's the Trump voter or whether you say it's the Biden voter, these people are feeling, I'm not getting a salary increase and they're falling behind. And this gets into debates that we're not going to get into today about international inequality in America, but the point is they're getting their compensation through healthcare. Again, average American makes $52,000. Healthcare in this country costs roughly $15,000 for a family. At the minimum wage, you're making $15,000. So you can see why people on minimum wage don't get a lot of healthcare coverage, because the McDonald's of the world are not going to pay their people $15,000 and also pay another $15,000 for healthcare. So this is a real challenge for people if it costs $15,000. So obviously, if you're working on Wall Street or working as a physician or a lawyer and so forth, and you're making 100, 200, 300, 15 becomes manageable. 15 against 50 is not very manageable. Now, Obamacare, the Affordable Care Act that President Obama ran on in 2008, did come through, largely got implemented in 14 or so. So the number of people who are uninsured, this 18%, there's roughly 325 million of us in the United States, depending on how the census wants to count people. So 18% before Obamacare came in were uninsured, roughly 50 million people. The program brought that down to about 11%. It's starting to inch up again because Mr. Trump is not enforcing Obamacare and making it as available to people. And when people can afford to pay care, part of what you get in Obamacare, especially if you're making $40,000, $50,000, $60,000, $70,000, you get a subsidy on buying health care. So essentially, if you're making $52,000, most of your healthcare costs can be covered by government subsidy. It kind of peters out at about $90,000, and people over $90,000 have to pay the full premium. But when people don't have enough money, they stop buying healthcare. Now, sometimes people, they like terms like let's put some skin in the game and have people pay for healthcare. Unfortunately, when people don't buy healthcare, they stop using things they may not need. They also stop using things they may need. So the evidence going back 30, 40 years is that if you put a lot of economic constraints on the purchase of healthcare, not everybody knows exactly what kind of image they need and what kind of tests they need. That's why people become doctors and nurses. The average consumer may know how to go buy a flat screen TV or car by going online. By and large, people can't self-diagnose themselves. So the whole notion that you should have people pay more and more for healthcare, because therefore they're limited. They'll limit some things that may not be necessary, but also will limit things that are totally necessary. So that's one of the central challenges in that. As you probably saw 2 years ago in the New York Times, about 40% of this country can't afford a $400 out-of-pocket bill. So whether that's for a transmission in your car or a medical co-payment or a tuition payment for your child, 40% of us can't afford a $400 out-of-pocket bill. So that just tells you some of the concerns about costs. So what do patients want? They want to go see the doctor or nurse that day. They want to do it, like everybody else now. We've learned how to use our iPhone to schedule things. They want to get scheduling. They want a lot more care settings. You see CVS is within 10 miles of 90% of us in the country. And those are, I assume almost all of you live in Philadelphia. There's a CVS everywhere. So CVSs are everywhere. People want retail clinics. They want urgent care clinics. They want to get it by phone. But then they want their care to be coordinated. Now, the notion that you'll walk into CVS here and there, an urgent care center here and there, and have that care then coordinated with the rest of your care is still a fantasy in my mind in terms of how to get it coordinated. So there's been a lot of market disruption the last 10 years. First of all, Obamacare became law in 2010. As I pointed out on a previous slide, it largely got implemented 2-3 years later. It took a little while to implement it. And then when Mr. Trump was elected president, he was running on repealing and replace Obamacare. Fortunately, this is the late Senator McCain. He voted no on repealing Obamacare, 1 vote, and that kept Obamacare from being repealed in 2017. There was also administrative actions and legal cases that are constantly challenging by the Affordable Care Act. So the Supreme Court will be deciding somewhat in the next few months or so as to whether Obamacare stays on. What else is happening? Drug prices are going up. One of our breakthroughs with the World Center in what's called immunotherapy, where we actually have cured cancer and leukemia and lymphoma. The not so good news, it costs about $600,000 per patient. And that's a lot of money now in part, the drug costs $475,000 of that. So there's a lot of concerns inside society. Obviously not all of us are going to be able to get treatments that cost $600,000, $700,000, $800,000. So how do you distribute that kind of care? Who gets first in line? Right now, the fact that it's just curing leukemia and lymphoma largely for children, it means that most of the people inside this room are not as eligible yet for that kind of care. But you certainly want your kids, if your kids have leukemia and lymphoma, to have that kind of care. But $600,000, $700,000 is a big shot. And a lot of drugs now you start seeing, even they're selling on TV, 100,000 here, 100,000 there. These new drugs are much more expensive than before, which is why the drug costs are such a big proportion now of the healthcare population. And recently, you had this jargon of surprise billing. People go to the emergency room and all of a sudden they get a $10,000 bill. So there's a lot of anxiety now about how much healthcare costs. Furthermore, this is a map of the United States, obviously, and the important thing here is there's different colors. And the more deeper orange it is, there's more spending. As you notice, the South has a lot more spending on healthcare. Anybody want to venture a thought as to why the South spends more money on healthcare? Retiring. And also what else? The poor people spend more money on healthcare. I mean, they have more healthcare needs. So the parts of the country that are poorer, you got West Virginia, Western Pennsylvania, New Jersey, and so forth. I mean, there's some exceptions. Obviously, Massachusetts is relatively richer and so forth. But basically, a lot of variation in terms of how healthcare is delivered around the country. And this is just a graph that shows the same thing. Healthcare is very varied. And part of my thesis that I'll argue later about what we're doing at Penn, you got to bring that variation down. You have to have what's called evidence-based medicine. You can't have this variation. This variation leads to tens of thousands of dollars of bills for patients. You have to bring that variation down. And I think we have a story as to how to do that. And there's been models the last 30 years where we're trying to pay doctors and hospitals different for healthcare. So an important takeaway from this is too complicated. This one I use more with our staff. The important thing to remember in healthcare, it's not just science and technology that drives what healthcare does. It's also financing, how you pay for it. And if you're charging $600,000 for a drug, you're not going to have as many people use it. The question is, can you bring that kind of price down? So just remember that financing as well as technology drives the way healthcare is delivered inside this country. Probably one of the 2 or 3 most important slides I'll give you today. 5% of us incur 50% of healthcare costs. This is true in Pennsylvania. It's true in San Francisco. It's true in Berlin and Amsterdam and London and Melbourne and Montreal. Advanced societies in terms of, like the Eastern European countries, Australia, New Zealand, Japan, us, and so forth, spend money on healthcare. And healthcare is concentrated on people sick. I mean, it costs, if you have metastatic breast cancer or prostate cancer, if you need a liver transplant, if you have premature twins, that's what healthcare costs are. It costs 100 times as much to take care of a sick person as a healthy person, which is why insurance companies want healthy people in the old days, because they don't want to cover people who are sick. And the key thing is, for me, is how do you reduce and manage the costs as best you can on that 5% of us, the 1 of 20 of us, who have all the healthcare costs. If you're 32 years old and don't have healthcare needs, saving 100% of healthcare costs, 100%, as you remember from arithmetic, 100% of zero is still zero. But if you're spending $50,000, $80,000 on healthcare per year, when you have breast cancer or stroke and so forth, that's where all the money is. So my thesis at Penn has been, let's figure out the old, even before my time, they asked Willie Sutton, why do you rob banks? That's where the money is. Why do you try to focus on the 5%? That's where the money is. So if you want to reduce healthcare costs in America, remember this, you have to focus on the 5% of us that have all the illnesses. Now, that 5% is not the same 5% each year. Because sometimes you get some cures from or you're in remission from your cancer. But those 5% of us each year, that's where all the money is. And to really bring down healthcare costs, or at least keep the rate of increase from going, you have to focus on that 5%. So sometimes when people, now I'm all in favor of, the head of our cancer center, a good friend of mine, he always says, by and large, if you listen to your mom, you don't have to go to medical school. Don't smoke, exercise, diet right, get some sleep, and by and large, you never have to come see us. I mean, genetics here and there will get in the way, but by and large, if you do those things, and if nothing else, I'll tell you, don't smoke. But and also get some sleep and diet right and exercise. But by and large, if those things, when luck comes or lack of luck comes your way, you come on that 5%, you come see us. Now, there's also market disruption coming from the private sector, with 18% of the GDP, gross national product, being in healthcare. The big players, Amazon, United is the biggest healthcare company in the country, so they're buying. United Healthcare now has employed 30,000 doctors. Amazon, with JP, the big bank, has created a company to come into healthcare. Cigna bought a big pharmaceutical company, and CVS, which I mentioned earlier, is within 10 miles of 90% of us inside the country, just combined with one of the bigger insurance companies. So a lot of disruption coming in the private sector as well. This is important. This is a Gallup poll on who we as Americans trust. And the bottom of the heap, that nobody trusts, lobbyists and members of Congress. and telemarketer and car salesmen. Hope not too many sell cars on the side. Who do they trust? Nurses, pharmacists, and doctors. So one of my theses at Penn is, as long as society still trusts us, as doctors and nurses, healthcare will still be organized by us. If we lose that trust, if we're seen as too mercantile, if we're seen too much involved in finance as opposed to involved in patient care, we'll lose that trust, which is why nobody trusts Congress, because everybody sees them as being on the take with lobbyists and so forth. So you want to be up here in the trust, at the height of the trust curve, rather than down here where trust is not secured. So since people trust physicians, one of the key questions now, as the American economy keeps being reshaped, how do you organize doctors to deliver better care? So obviously people like us organize it. I mentioned earlier that the United, the biggest healthcare company, the biggest insurance company in the country, now has hired 30,000 to 40,000 doctors. You start seeing retail clinics like CVS. CVS says, for those of you who are going to watch it the next couple of years, you're going to see, if you go to CVS now, you're going to see more and more of your CVS kind of be as a little mini medical mall. They'll start doing dialysis there. They'll have more doctors in there. I mean, they've always been selling drugs, obviously, as CVS, but now you're going to see little mini medical malls inside all your CVSs around the country. So the question is, if the doctors are the key people still in the healthcare system, who's going to organize that? And we're saying we're the best people to organize that. And another thing you need to know in terms of healthcare is we on the East Coast have a lot more hospital beds than out there in California. I mean, I would say out here they eat tofu, over here we eat cheesesteaks, so that's the reason that's a lot of hospital beds. And so if you're Comcast, if you have an office in Philadelphia, you have another office out in San Francisco, hospital utilization is 30–40% higher in Philadelphia than it is in California. Now the technology is the same, so that's largely a function of the lifestyle of the people who live in Philadelphia. And the same thing is true. The whole belt, this belt here has a lot more hospitalization than out there going back all those years. Furthermore, and this is just an evidence of that, this is our kind of jargon, but basically this bar is a lot higher than, this is utilization of Philadelphia. The important thing here, this bar is about half again as high as the bar in California. So a lot of hospital utilization. And you can tell Pennsylvania is higher than the rest of the nation. It's much higher than California. So a lot of hospital utilization here. If you're a national company, you're worried about those kind of things. And furthermore, there has been a lot of pressure on hospitals. Moody's, you all know who they are. Most recently, their outlook was negative. Not for profit. Those are hospitals like us and Jefferson and Temple and the community hospitals around here. So it's negative in terms of these cost pressures and people not wanting to pay as much. And margins are down. In 15, average margin for hospitals, and these are not the kind of margins you see in Silicon Valley. They get 40, 50%, 4%, 3%, 2%. Margins are going down. And furthermore, just 3 blocks behind me here, Hahnemann announced recently, April 3rd, 175 layoffs. The CEO says shaky financial condition, and they're literally under threat. There's a meeting of all of us going tomorrow, trying to make sure Hahnemann doesn't close. But that would have a big effect on this part of the city if they close. And we have one of our hospitals is out in Lancaster. The hospital right next to us, about a mile away from us, just closed 3 months ago. And so the hospital that we have, which is very full, all of a sudden now has 40, 50 patients a day that used to go to the emergency room at the other hospital, now just saturating our hospital. So when hospitals close, and they are closing around the country, you see the other hospitals around and all of a sudden get overrun in terms of what you do in the short term. And what you do when hospitals close, AHERF was the name of the Allegheny system. This is an article written 20 years ago, but basically pointed out if you take these hospitals over and in some ways you can really mismanage them. This is the biggest, still to this day, the biggest not-for-profit bankruptcy in U.S. history. This is 20 years ago. This is the Allegheny system out there in Pittsburgh. So they made a lot of mistakes, and one of the things we're worried about, those of us who are here in the city, is we hope the same thing doesn't happen to Hahnemann 3 blocks away. Hospitals are increasingly going into systems to consolidate. Sometimes they think there's safety in numbers, but one of the other professors at Wharton and I have written about this, and we basically pointed out consolidation doesn't lead to better outcomes if you don't actually focus on what you're doing once you're in the hospital. So I'm going to tell a story about Penn in a moment, but basically the national evidence looking at 5,000 hospitals over 30 years says consolidation by itself is not the answer. This is another critically important slide. If your care is coordinated, you probably know this from your own personal life or taking care of your mom or dad or spouse or family member, it's just cheaper. It costs half as much to have care coordinated as when it's not coordinated. This is a powerful slide. So what we have focused on in my time at Penn is how do you get the care more coordinated? And I'll tell you how we've tried to do it. But when care is not coordinated, it just, first of all, you get the diagnosis wrong the first time, and you do things over and over again. I mean, this is pretty intuitive to most people, but there's big evidence. This is from a study of the 100 big hospitals in the country, like Penn and Harvard and Stanford and every place in between. So what are we doing? First of all, do a little bragging here. We're a big place. We see, we have 6 hospitals. We're up in Princeton. We're out to Lancaster. We have, the hospitals downtown. A big flagship hospital called HUP, Hospital University of Pennsylvania. It's obviously over there in West Philadelphia. We're the 3rd biggest research operation in the country, big research place, one of the elite medical schools, ranked again number 3 by U.S. News. So a big patient care place, and we cover a geography. So what we try to do is figure out, to honor that slide, I showed you 2 slides ago, how do you get systemness? How do you make sure the care is coordinated? How do you make sure, therefore, that you bring costs down? So these are kind of, we focus a lot on these kind of concepts, and this is more than you need to know, but we really focus a lot on bringing the cost of care down by standardizing them. So what we do, we have the big hospitals like HUP and Presbyterian in Pennsylvania, but we have a community hospital in Chester County. This is, for those who live in Cherry Hill, this is the old Sims place. We're right there on 73. We have a multi-specialty place there. We have a big one now that we're building in Radnor again, and we're in Bucks County. We're everywhere. We have urgent care. We have primary care. This is out in Woodbury across the Whitman Bridge. And we're the biggest home care company in the region, as well as telemedicine. So we do telemedicine, we do home care, and then we have the big ICU and cancer therapy that brings people from around the world. We do the whole spectrum. Baseball fan, this is where the Phillies fans are. Here are the damn Yankees. Here are the Orioles. So I make sure when we locate our medical practices, it's where the Phillies fans are. Now, you're saying, well, why would you do that? I mean, the serious part of that is medicine reflects the local culture. Just as I was making a crack earlier about we eat cheesesteak and they eat tofu out there, and how you organize doctors, medicine reflects all the cultural attributes of a region. Healthcare is organized different in Philadelphia than it's organized in the Central Valley of California or the northern part of Wisconsin. It reflects the culture. Where that culture comes from, in the days when I was growing up, on over-the-air TV, or having SEPTA versus MTA, or having Macy's versus Wanamaker's and so forth, or whatever it is. Culture matters. And so for me, when we took over Lancaster, I made sure they had those Red fans as opposed to those Orioles fans there. Because Hopkins is right here and very close too. So the serious part of this is we locate ourselves where the cultural values are more resonant with and consistent with the values of Eastern Pennsylvania. So we, by and large, when hospital system, the banks may want to go to Topeka, Kansas. We don't want to go to Topeka, Kansas. We want to make sure we go from Lancaster to the Jersey Shore, up to Princeton. And I know north of Princeton, having grown up in New York, north of Princeton, they're going to be oriented towards New York. And southern Delaware, they're going to be oriented towards Baltimore and Hopkins. So we focus on the area where there's a cultural desire to be associated with Philadelphia. And we do it all. One of the biggest cancer centers in the world, big programs in heart and vascular, neurosciences, primary care, emergency trauma. We do it all. And we've been leading, we are the world leader in what's called immunotherapy, where basically we genetically modify your cells and your immune system to kill the cancer. We've done that, I mentioned, in lymphoma and leukemia, and that's we're the world center in that. And these are some billboards and copies we did. When a tumor attacks the body, that's cancer, and then we trick the cells to go kill that cancer. We work cooperatively with people. This is a picture of me with the head, Dan Hilfrey, the head of Blue Cross. Worked when we announced 2 years ago now a contract to really align the incentives between Blue Cross and Penn. We invest heavily in information systems, as Harrison said. We have a common electronic record everywhere we practice, whether it's in Lancaster and Princeton, in telemedicine, in home care, in the ICU. Nobody else has that in this region. We're the only one that has that. 500,000 of our patients have signed up for online access. So you get your doctor's notes, you get your images, you get your lab results, and we remind you of your medications and your allergies and so forth if you happen to go elsewhere. A big effort on telemedicine. We're the largest telemedicine hub in the region. So whether we manage your Parkinson's by when you have a family member with Parkinson's, getting in a car and coming down from Allentown can be a real schlep, so forth. Kind of managing that over the telemedicine is a lot easier for people, and we focus a lot through this telemedicine on keeping people out of hospitals. And then we also, once you have people who have strokes or Parkinson's or cognitive decline and so forth, we try to keep managing by hovering over those patients. Big efforts in innovation. As you probably know, we have one of the world's famous business schools at Wharton, right on our campus there. So we do a lot of collaboration with the Wharton crowd, taking the insights from social science and combining them with medicine. Because to get insights into big populations, having the tools of social science in addition to the tools of medicine are one of the critical things we have. So, for example, how many of you have heard of the word nudges and nudge units? Have you heard the word nudges and so forth? And I know the thing. So we were the first healthcare nudge unit. For example, a nudge a good nudge is about 20 years ago, most employers start saying now, we'll sign you up automatically for a contribution of 403B. You can decide to opt out, but by and large, we'll sign you up. And the rate of 403 contributions went up from about 20% to 80%, but it's just by, people now were automatically signed up in health plan. They can always say, I don't want to do it. Another important nudge is in organ donation. In Western Europe, you're automatically signed up for organ donation unless you opt out. As you know, in the United States, including Pennsylvania, you have to opt in. So the rates of organ donation are much higher where you automatically opt in. Those are, you still have a choice, but we got generic prescribing at Penn Medicine up to 99%. Just by the first thing when the doctor or nurse now prescribes a drug, the first thing that comes down is the generic equivalent. So we make it easy. We make it easy to make it easy, and therefore we have generic prescribing. So those are nudges. We teach people how to do things the easy way. So in sum, healthcare spending affordability will continue to be a big issue. I mean, if you watch MSNBC or Fox News or CNN every morning, you see the wing of the Democratic Party that wants to run on healthcare versus the wing who wants to run on impeachment. But my guess is if they're smart, they'll run on healthcare versus impeachment. But that's just my political sense on them. But that issue was a big issue in 16. It was a big issue in 18. It was a big issue in 20 for those slides I first gave you. On the other hand, spending will continue to increase because of my generation. Now, I'm still in good shape. I still played in the faculty student basketball game the other night. I'll brag about that. But the point is the baby boomers need health care. At 62, 72, 82, they're going to come see us. And as long as we're such a big cohort in society, and we vote, and we're employed, so we're going to keep spending. I mean, I'm all in favor of dampening the rate of health care increase. I'm all in favor of coordinating care. As I mentioned, we've done to Penn and really brought costs down. But by and large, rich societies spend money on healthcare. There's only so many flat screen TVs you want to buy when you're 70. You're going to buy healthcare. So whether you're living in Belgium, in the UK, or in the US, you're going to spend money on healthcare. Disruption will come both from the government, Obamacare, repeal and replace, Amazon, Apple. The other day I was playing tennis, and I was wearing my Apple Watch, and I kind of hit my stroke, and I hit my Apple Watch, and the Apple Watch starts beeping. You seem to have fallen. You okay? No, just a bad stroke. But I mean, the point is, if I had fallen, the Apple Watch was telling me, and if I had not responded right away, they do a little SOS and call emergency and so forth. So that's kind of Apple is. I mean, you may be worried about your privacy, but they're watching you there on that Apple Watch, and we can now do what is called echocardiogram off a Echo Watch, off an Apple Watch. It's amazing, and we monitor your blood pressure. We monitor everything now. We monitor right off an Apple Watch. So Apple is coming there too. Disruption is going to come from the Apples and the Googles. Now, obviously, we'll get into debate as to how much we want to share with the Apples and Googles and so forth, but they're coming in. Value-based is our jargon for meaning you got to get more money. You got to get more outcomes for the money you're spending. And I think my essential argument: bring down the variation of American healthcare. You can't have that orange map where we spend so much in the East and less in the West Coast. And to fix these things, I'm proud of my time at Penn Medicine. We do all this. We focus on the patient. We have the highest patient satisfaction scores by far, almost any academic place in the country. How you organize your doctors, your nurses, your IT, your training, and so forth. This is all healthcare's. Mr. Trump is the only one who doesn't understand that healthcare is complicated. But the point is, it is complicated. You have to do all this together to get it fixed. And if you change how doctors and nurses act to be more coordinated, integrate care, focus on patient settings, and focus on where the costs are concentrated, e.g. the 5 and 50, I think we'll have a good chance. So that's what I've been spending my time on the last 17 years at Penn Medicine. And I think we feel very proud of that. It's not just a name brand there. So we do the most advanced care. People come around the world for the biggest proton therapy unit in the world. At the same time, we're right in the front of all the innovations in primary care as well.